Hello, my name is Gerard Penting, and 10 years ago I was one of the founders of OTSIS, the Orthopaedic and Trauma Specialist Indemnity Scheme. OTSIS is a not-for-profit company, and it was established to improve the provision of medical negligence insurance for orthopaedic surgeons. OTSIS is a mutual, meaning that it's owned by its members, who are the surgeons that use OTSIS for obtaining their policies. We work in close collaboration with our insurance broker MIC, who will liaise with a number of specialist insurance underwriters to provide the most secure and comprehensive insurance policies for our members at the lowest possible prices. One of OTSIS's key USPs is that it's governed by a board of practicing orthopaedic surgeons who are elected from the membership. The board oversees the running of the scheme and ensures that members' best interests are put first at all times. To find out more about how OTSIS can help you, visit our website at otsis.co.uk.
Good afternoon to everybody. I'm really honoured to be moderating this next session on cartilage repair and the patellofemoral joint. We've got three fantastic faculty. So first of all, Seth Sherman, who I first met in 2019 at our sports knee meeting, where he brought his energy and enthusiasm. Seth last year moved to Stanford's south of San Francisco, where he heads up the fellowship program for sports surgery. He's also chair of the AAOS Sports Medicine Committee and also member of the International ACL and Patellofemoral study groups. From home, we've got Martin Snow, who's consultant knee and shoulder surgeon at the Royal Orthopaedic Hospital in Birmingham. Martin's also honorary professor at Aston University, where he oversees PhD students investigating stem cell cartilage repair. And then finally, Vipul Mandalia, who you all know very well. Vipul is a consultant knee surgeon in Exeter, where he's the research lead for the Exeter Knee Reconstruction Group. He's also convener of a great meeting, the Exeter Knee Masterclass, and has been the main driving force behind this year's British Patellofemoral Society meeting. He's also involved in the multi-centre international trials in cartilage repair. So I think you'll all agree that we've got three people who are very, very qualified in speaking to us today about cartilage repair in the patellofemoral joint. So what we're going to do is just run through four cases, if I can just get my clicker to work here. The aim is just to pose some questions really to these guys, and then we're going to go into some individual talks. So first up here, this is a case involving just the trochlea. This is a 45-year-old sales manager. He's one of these guys that has to do exercise every single day. He does gym classes, spin, weights, running, and does caving. He had some minor symptoms in his knee about 10 years ago and had an MRI at the time, which just showed a little bit of minor patellofemoral wear. But about 18 months ago, he hyperextended his knee during an obstacle course race, and this really triggered a period of pain. He had an MRI scan in November 18, which showed some partial thickness wear to the patella, very minor, and a bone bruise on the medial side of the trochlea. His knee was still symptomatic, so in May 2019, he had a steroid injection, and this allowed him to get back doing some obstacle races and a half marathon. However, not surprisingly, his knee became sore again, and an MRI scan in March last year showed that the lesion on the trochlea had actually progressed. The patella seemed all right, but the trochlea had progressed, and he had a 12 by 14 millimeter lesion on the medial side of his trochlea. And this fitted with the anteromedial knee pain that he experienced, particularly when loading his knee at about 20 to 40 degrees of flexion, and this gave him discomfort on stairs and slopes and kneeling and that sort of thing. So here's just some stills from his MRI scan, which shows this area of damage. So this is medial side of the trochlea. It's about 12 by 14 millimeters from the MRI scan. He's otherwise completely fit and well. He's a non-smoker. He's good muscles, no effusion. He's got full movement and normal alignment. So just if we can bring the guys back in on the screen here, we heard of the importance yesterday of conservative treatment in anterior knee pain. Just thinking of your thoughts on the role of conservative treatment here at this stage of a guy who's had symptoms for a couple of years. and also what your thoughts are about injections, steroids, HA, maybe PRP. So, Martin, I'm just going to come to you first on that.
Yeah, so this is the sort of guy that I would try and fully exhaust conservative treatment. He has a couple of worrying features for me. One is medial trochlear lesion. In my experience, these do not do very well with cartilage repair, because I think it's difficult to identify why they have a medial trochlear lesion, except for sort of varus, femoral retroversion, low TTTG. It's difficult to identify the cause, and as a consequence, there's nothing really to reverse it happening again. So in these ones, especially if they're high demand, they're on the wrong side of 45. He's got a number of poor prognostic factors, so I would try and exhaust it. Physio.
Do you try HA injections or PRP? Seth,
yeah, no.
On that, I know you do injections in your sports med practice in the States.
Yeah, I agree. You hear me?
Seth? Yeah, Seth, you carry on that.
Yeah, I agree with Martin that this is certainly a patient I'm going to exhaust conservative management. He's, operating outside of his envelope of function. And so, kind of readjusting expectations, at least for a short time, while we optimize core to floor rehab. Injections, certainly if there's a boggy effusion, can be helpful. It really will depend on insurance. So I'm fine using high molecular weight HA, typically bacterial fermentation, 1 or 3 doses. So it may be different across the pond what you use, or leukocyte reduced PRP. And just to finish with your point there, I'm okay also using Kenalog. We've shown in the lab and in vivo studies that it's safe for cartilage compared to others, and I do not use local anesthetics. But I think that combination can try to get him to fall out of the algorithm and continue to treat non-surgical until he fails, and hopefully he doesn't.
Okay, so Vipul, just coming to you on this question then of if we're satisfied that this guy has exhausted non-operative options, so would you consider cartilage repair in this case? Does cartilage repair actually work in the patellofemoral joint? Professor Cobb yesterday was telling us the PFJ will last for years, well, forever, I think his words were, if it's normal. But if it's not normal, we're going to struggle with repair techniques.
Yeah, so I think the first thing is, as Martin and Seth said, once non-operative treatment and all other measures are exhausted, patient understand what's happening. And if the rehab is appropriate in the selected case with appropriate lesion, cartilage in PFJ does work. And I can understand why that question is there, because if you look at the biomechanics of PFJ, the forces that goes through PFJ, depending on your activity, can be anywhere between 3 to 7 times the body weight. So it's the right thing to question that, whether it works or not. But if it is done in a right way, after exhausting right treatment, after educating the patient, and understanding that patient is going to comply, what is going to be needed, I think it does work in PFJ as well. And hopefully we should be able to see that later on.
Okay, so just come to Martin then. If I had to push you, Martin, on this guy, if you were satisfied he'd completed non-operative treatment, what would you do for this lesion? Medial side of trochlea. If those other factors were normal, let's just suppose, what would you do for this lesion?
I would probably say that, I would offer him the best I can offer him at the moment, and the best that I could offer him at the moment would be, in terms of cartilage repair, would be ACI. If he was more sedentary, then I might be thinking maybe about mini implant type scenario as they get closer to that sort of 50 age group. Okay. But yeah, if I was going to optimize, my biological option anyway.
Okay, what about single oats plug?
For me, it makes no logical sense to do oats in the patellofemoral joint. So I'm going to rob from one part of the patellofemoral joint to implant in another part of the patellofemoral joint. So it's an absolute no for me in terms of oaks in the patellofemoral joint.
Okay, fine. Right, we're going to move on to the next case. That's raised some interesting points. So this guy, 46-year-old.
Peter, can I make a...
Yeah, 46-year-old policeman who I saw a couple of months ago. He had a 5-year history of right knee pain after being kicked at work on the front of the knee. He had an initial debridement after his MRI showed some damage to the patella, but had continuing symptoms. He then had a microfracture procedure to the patella about 2 years ago, treated in another hospital in the north of England, and unfortunately had ongoing symptoms, usual thing, pain on stairs, slopes, kneeling. He had some night pain. His Oxford knee score is actually only 9 out of 48, which is pretty severe symptoms. This is limiting his ability to work as a policeman, and he describes a feeling that the patella is actually dislocating. Now, actually, when you examine him, you can see that he's a slim, well-muscled guy. He's got perhaps very slight varus alignment, but certainly nothing major on alignment. He's got full knee movement. His patella height and tracking is actually normal, and there's no increase in lateral glide to suggest any form of instability of his patella. Now, what he does have, though, when you examine him, is an audible clunk from the patellofemoral joint, and it's that gives him this feeling that the patella is not in the right place. That's what he really means. Now, if we look at his MRI scan, and again, I've only got some stills on this case, you can see that he's got some osteochondral damage to the medial facet, just crest really of the patella. And this is an MRI scan taken in December 19, so that's just over a year ago. And this scan was done, just to be clear, after his microfracture procedure, maybe a year or so after his microfracture procedure. We think his patella height is actually normal, and as I say, tracking normal and trochlear anatomy normal. So if we bring you guys back in again, Seth, any alarm bells from you on the history here?
Yeah, I think, certainly, in America, we have workman's compensation, and, I'm concerned a bit about that with any type of a work injury. Also, I always get concerned when their subjective outcome scores are lower than what we might expect for, our classic cartilage restoration patients. And I think Christian Latterman and others have showed that if you go into it with that much debility, that you may have a ceiling on you and never get out of that. So, I worry about that. But most importantly, I worry, for this patient that this is one that may have done okay with non-surgical treatment to begin with. But at this point, he's 2 surgeries down. I personally don't microfracture in the patella. So now we have an osteochondral painful problem in an otherwise well-aligned person. I think he unfortunately at this point needs, a salvage surgical intervention, whereas it could have been all potentially avoided early.
Okay. Does microfracture work on the patella? I'll put that to you, Seth, while you're still on the subject. Given that it's a sesamoid bone, does it actually have a chance of working?
I don't use it in my practice, and I think that the vast majority of surgeon colleagues here in America don't use it for the patella either. There's multiple reasons. I'll go through a few in my talk later, but I think if you're going to do it, one, you have to stick to principles, so you have to optimize the environment if the environment of malalignment exists. And 2, I think you probably have to do it mini open and get good stable vertical walls and either deeper, smaller, so stick to principles, microfracture, but still there, I think, the fibrocartilage in a high shear environment and the less cells available, potentially limit its efficacy.
Okay, thank you. So Vipul, just going to come to you now. What are we going to do next for this guy? So let's just put aside the concerns about the work injury. Those are exactly the alarm bells that came up for me that Seth just summarized there. But what are we going to do? Put that aside in this type of damage on the scan. What would you do next?
Yeah, so I think once we have got no concern and patient is optimized, this patient on the scan, it already shows that there is a cartilage problem, but also problem of the subchondral bone. The scan that you showed was in December 2019, so it's almost 13, 14 months since that scan. So as you have already written, repeat MRI scan will be useful. One of the other things that I do, probably not for pure patellar lesion, but patellofemoral lesion, is do arthroscopy as a stage one as well. And I don't know what Martin and Seth feels about it, because patellofemoral joint is not easy to assess in detail with MRI scan because of the cut section. So for me, two things. I want to understand the lesion in detail, either with just MRI scan or with stage arthroscopy. Most likely it is going to show that there is a bone involvement as well, subchondral involvement as well, and cartilage repair does not work well if you have got suboptimized subchondral bone. So then my options are, how am I going to replace subchondral bone and cartilage? In theory, three options. I can do bone grafting and cartilage transplant, ACI, or OATS, which I don't do. And the third one is osteochondral allograft transplantation, which I have done. However, in UK, the availability is not as great as in US for some reasons, which we can discuss later on if you've got time. So my go-to option, if I got osteochondral allograft available, that's what I would do, because it will address both cartilage and subchondral bone, relatively quick recovery. But if not, I think I'll go for bone grafting and ACI in my hand.
Okay, fantastic. Right. Martin, I'm just going to come to you to ask same thing, just sort of the commitment on what you would do for this lesion. And then I'd like you just to sort of, in general principles of how you would rehab somebody from cartilage repair surgery, given that, yes, there's various options, but the general principles of what you do with your rehab, please.
Yeah, so this guy, again, this is another step up from the previous case, and it's even worse because we've got a failed microfracture. So again, yeah, for me, by definition, he's got a clunk, he has patellofemoral maltracking, so I'd really look for a reason. Is this a functional or an actual? In terms of the cartilage repair, I'd be looking to trying to do an associated if I could, to try and improve my outcomes. But in terms of the actual repair, yeah, so ACI wouldn't be allowed in the UK because he's had a previous failed repair. Allograft, again, difficult to get for this lesion, and funding is an issue, but I think is probably the best option. So if he was in my products, I'd have to excise the bone graft, and then I'd probably use a BMAC and a graft. Rehab, for me, it's pretty rare that I do a patellofemoral cartilage repair without an associated procedure. So often the rehab is dictated by the associated procedure as much as anything. But depending on the location, graduate activity accordingly, and on the technique. But it's incredibly conservative, really. Low impact. No running for at least a year, or impact activities for a year. But it's incredibly slow, and like I said, I'm always worried when I can't do a associated procedure, because I think that the repair is vulnerable to breaking down, particularly when you can't do or transfer to a hyaline cartilage as in a OCA.
So first 2 months, you bracing them? How much movement are you allowing?
Again, it dictates by the location of the lesion and what I've done, but it's usually most people have had something done, either an anteromedialization or something on those lines. So yeah, usually they're restricted to 30 or 40 degrees for either 2 or 4 weeks, depending whether they've had a tubercle osteotomy, 90 up to 90 by 6 weeks, and then I remove the brace comes off then after that.
Okay. So just before we move to the next case, Seth, anything else to add just very briefly on rehab? Any other points you wanted to make about rehab?
Yeah, I'll just make a few points in general. MRI, I agree, grossly underestimates size. So staging arthroscopy is a big part of my arsenal, as we'll talk about. I think microfracture does burn those bridges for cell-based, which would push me towards an osteochondral solution for this patient. This one I don't think needs a concomitant procedure, although I'm quick to add osteotomy, as you'll see in my talks. And then rehab-wise, with a straight osteochondral allograft, I'll keep him in a brace. I'll keep him toe touch, for a couple of weeks, but then I'll wait for his tolerated locked, and I'll start CPM right away. Basically to tolerance. I'll use blood flow restriction therapy early to reduce the risk of atrophy and to promote muscle hypertrophy.
Excellent. Okay. Well, yeah, all of those things freely available on the NHS, obviously, Seth. Right. So next slide, we're just going to, right. So this one, 34-year-old woman. She's a psychologist. Had anterior knee pain as a child, had to give up ballet. She remembers she's never been very sporty, fairly sedentary lifestyle. In November last year, this is a familiar story, I'm sure, around the world, developed knee pain after doing lots of walking because of lockdown. She felt that her kneecap was loose, but there's never a suggestion that actually there's been an instability episode. She gets clicking from the knee. Now she's 5'7". She weighs nearly 100 kilograms, and that gives a BMI of 34. The upper healthy weight range for her height is 72 kilograms. So we've got some issues there. Her MRI, we've got a still here that the arrow just points to this 15 by 15 millimeter full thickness lesion on the lateral side of the trochlea. And there's some partial thickness patella damage that's developing. And if we go to the next slide, you should see from the video run through of her axial MRI, the size of this lesion. You can see that the trochlea is fairly flat. So there is some degree of trochlear dysplasia, mild here. The patella height is actually good, but there is some damage now developing on the patella. The sagittal run through shows that the rest of the knee is actually fine. And yeah, I think confirms our patella height's pretty good. So I think you get the gist of this. So coming to the questions, I think how long do you wait before considering surgery? I think we've probably dealt with that already with the first case, talking about conservative treatment. So BMI, guys, where do we got to? Let's Vipul, we're going to come to you. What are your thoughts about BMI? Do you have a limit? Obviously, this lady, we're going to strongly suggest she drops her weight, but does it work? Do people lose weight? What's your BMI limit?
So I think BMI under 30 is always better in terms of cartilage regeneration. And as we saw yesterday, and we know from the literature that the amount of the forces that goes through patellofemoral joint is 3 to 7 times body weight, depending on your activity. So it makes it's straightforward. Lose your weight, because that is going to reduce your forces going through the joint. Will I do ACI with high BMI? Probably my first answer will be no, but that is not to say that I will never do ACI in a 32 BMI or something like that. I think it's about how much effort is made in losing BMI. Are there any other prognostic indicator to reduce the outcome of cartilage transplant, which in fact in this lady there are. She has got abnormality for last 15-20 years. I mean, symptoms for last 15-20 years. The pattern of wear and tear to me suggests that it is more degenerative rather than a pure chondral lesion related to cartilage regeneration that can be done. So I think putting those things together in this particular case, I think BMIs are definitely against any attempt of cartilage regeneration. In fact, you probably will discuss the next point, kissing lesion. But if you combine long-term symptoms, lateral compartment pathology of the trochlea and the patella, high BMI, to me, it is absolute no-no for cartilage to start with. We need to look at the realignment, and we need to look at those aspects as well, but not as a starting point in this particular case.
Okay, thank you very much. So Martin, going to come to you on the next point then about kissing lesions. So again, yes, this person, the BMI, we've covered that, but just some general principles about kissing lesions. Does cartilage repair work with kissing lesions? How do you address them? Just your thoughts on that, please, before we come to Seth on realignment.
Yeah, so kissing lesions, it does tend to suggest more of a chronic issue or a degenerate issue. I would probably have a slightly different viewpoint than Vipul. I would probably be more aggressive. Unfortunately, this patient is probably going to be mine for the rest of my life. So consequently, what I don't want to happen is put her off with conservative treatment, her turn up 5 years later and she's sort of bone on bone grade 4 PFJ. So for me, I would just have a serious chat, discuss weight loss and things, but then I would actually probably look to be reasonably aggressive given the fact she's only 34. I would anteromedialize to offload that lateral facet, and because she's 35, I would do a cartilage repair. But I think kissing lesions for me it's a failing joint essentially. You're in a degenerate situation, but it doesn't change the fact that they're only 34 years of age. So I'd rather fix it now and try and slow it down than be faced with frank OA in about 4 or 5 years time.
So I appreciate you've only just had a quick run through looking at her MRI. The patella wasn't full thickness. What would you do anything to her patella there at the time of surgery if you're doing ACI? So you're anteromedializing the tubercle, your ACI to the trochlea. Are you doing anything to the patella?
I would just assess it. So if you were planning to do an ACI, then I would at the time of the biopsy and the arthroscopy, I would assess the patella, and then I might plan my measurements to or add on maybe another couple of square centimeters when predicting the area of coverage, so that you get enough chondrocytes, and then I would reassess it at the time of the procedure, basically, because I would probably do it through a mini open and then just have a little look at the well, it wouldn't be mini open because she'd be getting a focusing osteotomy, but I would just extend the incision a little bit, and that focusing will allow me to flip the patella and then sort of manually look at it and feel it and decide then.
Okay. So Seth, how do you judge when to add in realignment procedures?
Yeah, I think I'm always thinking about alignment first, and if I can offload cartilage and avoid cartilage restoration, particularly in a challenging patient like this with a high BMI. And so with bipolar, even if one side's partial thickness, lateral-based defects, shallow dysplasia, tilt, likely borderline or elevated TTTGs or TTPCLs. I mean, I'm fine with cutoffs that are lower than our instability population for doing this, because it's going to be mostly an anteriorization effect and some medialization, but not to over-medialize. So 15 or above TTTG on an MRI is totally fine for me to do a steep osteotomy. And I think that's the treatment of choice for this particular patient with a lateral retinaculum lengthening and likely without cartilage restoration. Okay,
excellent. Thank you very much. Right. So final case, this I got from Andy Metcalf. The videos are perhaps a bit squashed here. So this is a 16-year-old boy who had his first dislocation of his patella about 3 years ago. He had an osteochondral fracture to the patella that was fixed back. Unfortunately, this lad is an apprentice bricklayer, and he's set his sights on doing manual work as a career. Now, I'm sorry, you guys, it seems the videos aren't running or the view of the videos is not great, but essentially they show that he's got definite trochlear dysplasia, like a dome trochlea, and there's full thickness damage to the trochlea and also to the patella. He's only 16 years old and wants to do a manual job. He's got symptoms of pain and instability. So apologies that the videos are not as we can see them on the setup. But right, Seth, coming to you here. What are the limits of cartilage repair in the patellofemoral joint, and are there any options for this lad at the age of 16?
And I can't tell, he's not obese, correct? He's
correct.
Normal.
Yeah, he's slim. Yeah.
Yeah, I mean, this is a challenge. He's young. This is one where we need to be thoughtful, not burn bridges, and probably offer him a comprehensive platform. I think taking inventory problem list, even if that includes staging arthroscopy, is appropriate. And then maybe even staged larger procedures for this kid, especially if you think you need to treat the trochlea to manage his instability, or if you're thinking of combining at some point some restoration of the surface with trochleoplasty, which I have no experience, or if you need to do TTO plus some of these other things. So I would be thinking about cell-based restoration if the bone's involved, bone grafting. So really not moving towards a bipolar osteochondral solution at this point, certainly optimizing the environment. And then inherent in any instability case is balancing the soft tissue, MPFL reconstruction, and lateral lengthening if there's tilt and tightness.
Fantastic. Martin, just any other points from you on this guy, this young guy, before we head on to the talk?
I would say there has to be a driver to be this bad, this young. There's got to be some other reason other than the dysplasia. Definitely look for that. I agree with Seth. And Andreas Gummel has just showed that ACI isn't really affected by the level of dysplasia. And so I would start there. And then you've always, all cartilage repair will fail. So you've got to think about the next, because he's only 16, the next 10 years. And then potentially then you've always got the osteochondral allograft as your salvage from your cell therapy. And then, you just sort of kicking that can down the road.
Okay. Martin, with the caveat, though, that the dysplasia may not influence ACI, but most of those cases we're unloading with a TTO. So you might not treat the we are optimizing the joint.
I would definitely say he's probably got a rotational issue. To be that bad, that young, there's something that's driving that, and that needs to be corrected, number one, for sure.
Fantastic. Okay, I have had some questions come through on the WhatsApp, which we will come to later because we have got some discussion, but we've run out of time there. Those were 4 very interesting cases that have come through the door. Well, the first 3 to me within the last few months. So they're real life cases. What we're going to do now is move to specific talks now. We're going to start off with Seth, who's going to be talking to us about osteochondral allografts in the patellofemoral joint, and then move to Martin, who's going to be talking about BMAC, and then to Vipul about Macy within the patellofemoral joint. So I hope you found those real life cases interesting and that those raised some useful points. Seth, over to you.
Thank you very much, Peter. While they're loading my talk, I'll just say that I'm just so grateful to be here. And, it's a challenging time, and I always learn so much from these interactions. So really, really appreciate it. So I have the task here to talk about osteochondral allograft indications and techniques. Not sure how familiar or unfamiliar, much of the audience is, but we'll give a relative overview of when and how I use it. And then in my next talk, we'll go through some of the evidence. This is a paper I wrote with Bill Bugbee. He's arguably has the most experience in the world with osteochondral allografts, and it goes through a lot of the principles in more detail. So I encourage you to read it if you're interested. Let me just start by saying that cell-based repair is my workhorse. So if I have a young patient, and that's a moving target, but normal joint spaces and no osteophytes. So I'm really critical of my x-rays. I need good x-rays. And they have a medium or large patella, trochlea, or a bipolar cartilage defect. I'm really treating those with cell-based repairs, especially those that cannot just be unloaded. So those central, medial, or panpatellas. Additionally, if I have a multifocal, large chondral lesions, so that's patellofemoral and condyle. Again, I'm treating those with cell-based, either with normal or a corrected mechanical axis. And so where does that leave us for kind of OCAs? I think the evidence will tell us that older age may drive us in that direction. So by evidence, it's greater than 30, even though I'm 41. Early osteophytes are really important, and early joint narrowing. I've been fooled. I've led myself down a path of cell-based repair in some of these patients. It's really a cross-section of early OA, and you can get burned. I think the compromised bone bed. So those are OCDs. Of course, you can do sandwich techniques, as we'll hear about, but you also can do a bone and cartilage solution if available. Subchondral cystic changes, not just edema with an intact plate, but actual cystic changes. And then prior marrow stimulation, I think that it burned bridges, as we talked about, for cell-based repair. And this is an excellent solution for that. or frankly for failed cell-based repair, or frankly, even in some instances, a good solution for failed osteochondral allograft itself. Sorry, my clicker went away for a second. When do I consider the allograft? So uncontained lesions, you could do cell-based, and there are special techniques for that, or post-traumatic, especially if there's an arthritic component, and avascular necrosis. So that's really the gamut. Really, we're replacing the abnormal cartilage with mature hyaline cartilage. The goals are the same as the goals of any other cartilage restoration technique: function, pain, and return to activity. The advantages, yes, it's single stage, but I agree with Vipul that we're really treating most of these with staging arthroscopy, and most things are two-stage when we're talking about large defects. It does treat the osteochondral unit. There's no donor site morbidity. There's really no significant size limitations. We have great ways to match donor and recipient these days. And it's mature hyaline and secure press-fit bone, so we can accelerate the rehab, at least in the early go. But we need time for creeping substitution, and so we can't really accelerate the later rehab towards impact much more than Martin alluded to. And then disadvantages, obviously cost, availability. We'll talk about cell viability, the allograft risks, which are low but real, and what your bailouts are if it fails. You're certainly pushing the cartilage algorithm over to the right. OCAs are all about viable chondrocytes. Favorable outcome correlates to chondrocyte viability. And so we don't want to mallet these hard. These are press fit either with our thumb or very gentle tamping. And the way that we do this technique really ensures that we don't destroy the chondrocytes before they even have a chance to work. This requires great teamwork and communication, both with the industry companies and also with your own team as far as insurance approval, tracking the grafts through the tissue banks, getting them into patients. We really have short windows, which is a disadvantage versus growing cells and doing it at your leisure. And so if you're going to do this, you need to have a good system. This is what's available: the whole patellas, the fresh pre-cut cores that are 10 and 16 millimeters, and then the trochleas and bicompartments. And so the technique is the same as the condyles. We basically size the recipient. You want to make sure that you go to the donor and that you have enough before you start reaming the recipient bed. So that's a big pitfall I always tell my tech and my team on the back table to remind me to do. And then we basically center on the defect. We place a guide wire. We mark the 12 o'clock position. You can score, as you see on the far right. And then we ream using copious irrigation. We want to ream 6 to 8 millimeters maximum. You can dilate as well. And then we size and resize to make sure that we have the exact specifications. Then we go to our donor, as you see on the right. And we do the same exact thing on the donor. We wash the marrow elements out, and then we can consider dipping in a biologic. This is controversial, but bone marrow aspirate concentrate has been shown at least to improve radiographic integration. It has not really been shown to improve MRI integration. There is some basic science on it, superior to PRP, but I think it's reasonable because bony integration and creeping substitution, especially with large grafts, is our biggest issue and our biggest problem. Just to go back here, we can bevel the edges. We gently press fit into the defect. Just a note for the patella, it's very dense bone, so we might need to step ream, not going to your 18 or 20 millimeter diameter right off, but in fact, starting with a smaller diameter and building up, that might help you. Here's a case. So a failed microfracture and an MPFL repair. Alignment parameters were normal. So we salvaged that with an MPFL reconstruction and an osteochondral allograft. And you can see how it nicely contours, even though it passes the median ridge. For the trochlea, central trochlea can be challenging. You see that it's not very stable. The guide, you can obviously do one on either side of the mid-groove, but this proprietary guide is more stable. It has 4 points of fixation, and I encourage you, if you're doing this, to try to use a guide like this or this guide to get the job done, and then the rest of the technique is the same. Here, again, is a patient who had a scope microfracture of a central trochlea defect. He came to me with frank debility. Here's what this looked like to open. Here's what this looked like after we were able to put in the fresh osteochondral allograft. So we can get really nice contour matching the native anatomy and early range of motion. Here's another case, 35-year-old with avascular necrosis, status post-chemotherapy. In this case, really alignment, stability were good. It's really just unstable osteochondral. And so this was a large and oval defect, and there's proprietary instrumentation, as you see here, where we can contour a large oval osteochondral allograft. The fresh pre-cuts are new. We don't have a lot of experience with them. There's increased availability. We don't have to size match. Similar concern to OAT as far as cartilage thickness in the patella. I think time will tell. But for patients who have a traumatic blow like this kid, there's good stability, there's good trochlea, there's a focal defect. I think it's an intriguing single stage option to explore. And the technique is exactly the same as you might do for your OATS autograft. And so hopefully I showed you how OCAs are a critical component of my algorithm. Salvage for failed prior surgery and a compromised bone bed. Primary indications are expanding, post-traumatic, AVN, OCD. And if we stick to principles, indications, and surgical technique, I think we'll improve patient outcome. And so look forward to discussion later. And I thank you very much for your attention.
Fantastic, Seth. That's a really good run through on osteochondral allograft. Some very interesting cases there. And thank you for sticking to time as well. So that leads us really nicely into Seth's talk about outcomes of cartilage repair in the patellofemoral joint. So Seth, back to you. And then after this, we're going to go to the questions and answers. We're still going to have 10 minutes for that because I know we have had some questions come through. Seth, over to you.
That's not good. It's rare that I'm that quiet. But hopefully this talk will bring together many of the principles we've discussed. The cartilage repair landscape is confusing. I like this diagram looking at those single stage, easy, cheaper procedures down to the more expensive and difficult ones, balancing fibrous versus hyaline or hyaline-like. And so this is an important paper I'd encourage you to read from the MOCA consensus group. This is surgeons who do a lot of osteochondral allografts, but it's really more about the patellofemoral joint. There's a lot of concordance in our statements, particularly with relation to alignment, optimizing the environment, stability, and there's still some discord in our ranks regarding the optimal treatment, ACI versus osteochondral allograft. But, in America, like in the UK and elsewhere, we have insurance challenges. We actually just had to write a letter challenging the conception that the patella is not a weight-bearing joint. We had to write that in the letter. And in fact, got some of these techniques approved by some of the insurers. But this is what we presented at ICRS last year. If you go by evidence, you're really going to stick with ACI and osteochondral allograft, and you're going to be guarded when we're talking about essentially every other procedure that I may mention in this talk. But I think it's critical that we're not just pigeonholing ourselves thinking about the technique. As you see here, to achieve success, we need to think about the risk factors, the etiology, the location, and there's just a lot more to it. Not every patient is the same. We need to be systematic in our approach, and there's really no cookie cutter. I can't tell you what to do in each scenario. I can only give you the underlying principles. I love this diagram. It really allows us to think about why there's a cartilage defect. Is it from an instability event, as we saw in our case? Is it chronic maltracking? Is it direct trauma, a lot of the time to the superior patella? Is it repetitive microtrauma to the central trochlea? Is it varus or valgus? I think having this framework really helps you to key into the diagnosis and the treatment. And then really knowing in the back of our mind, trochlea, it may be more common in men, older, fewer associated risk factors. The patella, really more females, younger age, more risk factors, more apt to want to really optimize and correct them. And this is my favorite slide, thinking about the joint as an organ. thinking about alignment, stability, and then cartilage to get the job done. And I always think about that when we're talking about what drives our decision to treat. I think, can I fix the problem with alignment correction alone? If I can, I'm done. Do I need to add stability? And then do I need to add cartilage restoration? In that order. We spend a lot of time on non-operative treatments. We've outlined this and discussed it previously. I find this a great way to gauge our patients' commitment, compliance, and response to treatment. We want to establish a rapport. These treatments that we have, the larger ones, can have long and drawn out rehabs. As Martin said, we own these patients forever. So we really want to establish that connection early, especially if you get into trouble at any step. I strongly consider staging arthroscopy. Imaging underestimates the size of these defects. I think the staging is a great time to think. We can correlate the history, physical, imaging, exam, our intraoperative findings. Some patients actually do well with debridement and don't need the big procedure. And we can see if our patients will comply with simple things before we do larger or more morbid interventions. So here's a patient that had 7 years of painful effusions. Their imaging studies really were unimpressive. Their scope showed a large focal cartilage defect of the central patella. We can assess the environment. We can assess the tracking compared to the opposite knee. Consider taking a biopsy. We always make a future plan and put it in our operative report. And then we can refer to that as the patient comes back. We can rehab, we can consider biologics, and if they fail conservative treatments, then we can execute the larger planned realignment plus cartilage restoration. The most common things I do alongside cartilage is TTO, MPFL, and lateral lengthening. The most important one, as Jack Farr and I alluded to in our arthroscopy infographic, is realignment osteotomy. This is important. If you cartilage map and you have these distal lateral defects, John Fulkerson has showed us that an isolated anteromedialization TTO without cartilage can get the job done, 80% good or excellent results. However, if you have patients that have these central, medial, or pan-patella defects and you realign them, you do need to add cartilage restoration to get those results upwards of 75 to 80%. And so I think that's critically important. If you have this kid who's dislocated multiple times, they have painful effusions between episodes, likely relating to that very large medial cartilage defect. They have a lateralized force vector with an elevated TTTG. You may worry if you do your TTO that you're going to load the medial lesion. But I would submit to you that if you treat the joint as an organ, you add cartilage restoration, you don't over-medialize, you anteriorize, and you add soft tissue stabilization, you can get the excellent result that you're looking for. And frankly, ACI with osteotomy is way better than ACI without osteotomy. So be very quick with your cell-based repair to optimize the environment. This is a national database that we looked at 1,000 patients last year and showed that concomitant osteotomy at the time of cartilage restoration reduces your risk of reoperation with a similar rate of complication and similar overall cost. So I think you all, I believe, are more inclined towards osteotomy. The American surgeon is a work in progress, but those of us who are doing this work are doing a significant amount of realignment. And then there's the debate when you really need to add it. I think if there's this lateralized vectors you see on the left, patella alta, severe dysplasia that we may not be addressing. We already hit on the bipolar, those with arthritis, young active patients. Those are all in the group where I consider the realignment. Here's a paper we presented at the Patellofemoral Study Group last year. So these are basically my series. These are patients. If they needed TTO to correct a lateralized vector, patella alta, or to unload cartilage, we did that. And then for those patients who had cartilage defects we couldn't unload, so central, medial, or pan patella, those are the ones that we wound up doing cartilage restoration on. And we basically compared the two groups. We had 31 patients who required cartilage restoration. We had 113 patients who were more of the standard instability patients. As you might expect, the cartilage restoration patients were significantly older, 25 versus 20. and their scores started worse. So their KOOS scores, their SANE scores were lower than the other group. However, if we stick to the principles we've just talked about, they actually come right up in their KOOS scores equal to the stabilization group. The point being is that if we're thoughtful in our algorithm, we choose patients appropriately, I think we can get good outcomes across the board, including cartilage restoration only when necessary, and no significant difference in complication rate. So that was good to see in my own practice. Here's a systematic review and meta-analysis I did with Bettina Hinkle last year, looking at 59 articles in the patellofemoral space. There was a range of diagnoses and treatments. As you see here, it's kind of a mixed bag. Only 6% osteochondral allografts in this grouping. A variety of lesion sizes, follow-up, associated procedures. There were more osteotomies in the cell-based groups, which may bias our results, as you see, versus osteochondral allograft. But after extensive analysis, we can see really there's no difference across the board in those subjective outcome scores between those groups. It was nice to see overall minor and major complications were not very high, and failure rates overall were quite good. However, in this grouping, osteochondral allograft did have a higher rate of failures. And so whether that's because that group had less unloading osteotomies, whether it's because they were larger or salvage defects, whether it's because the techniques were shell versus plug, really is hard to tease out from this type of a study. I will tell you that if you look at Bill Bugby's isolated series for single plug patella or single plug trochlea, those outcomes are nothing short of outstanding, as good or better than the majority of outcomes we see in the rest of the cartilage space. However, if you look at his outcomes for bipolar defects, those failure rates go up and the survival goes down. So I have a real guarded prognosis, and I really am selective about who I might perform bipolar cartilage restoration in. Here, with the plug versus shell, you can see the survival, the shell technique on the right versus the plug technique on the left. So I try to do plugs if and when possible. The bottom line, our conclusions, is that most of these techniques, when done appropriately in an optimized environment, can improve outcomes, low rates of complications, and really no significant differences between them. Just want to give my take on a few of these techniques in my remaining time. Obviously, if we can repair an osteochondral fracture, we want to do that. Here's a huge fracture, internal fixation, and soft tissue stabilization. I think it's interesting that when we look at the literature, besides techniques and maybe small series, there's really not a ton to guide us, but I think intuition tells us if we have these young patients, we have bone on the back of the defect, we really want to be fixing them to try to save the joint. However, we're also learning that we can do cartilage-only repair in these skeletally immature patients. So here's one. You can see a pretty large patella defect. And for this one, I used a knotless suture anchor centrally, and then I used fibrin glue on the periphery with some 6-0 sutures. And so you can use kind of hybrid technique to get this job done. And I think the evidence here, here's another elegant case using suture only that Jack Farr showed. So there are different options to do for cartilage only. And I think the literature is catching up. So don't throw these fragments away. You should fix them at time 0. That said, if you have the first-time dislocator with irreparable lesions, there's not a lot of data that says we should be aggressive in our initial cartilage restoration. So I would really caution you that if you can't fix it, maybe debride, take a biopsy, see how they do, stabilize the joint, and come back and follow your standard cartilage algorithm. That said, if you do fix the fragments or if you do cartilage restoration in the setting of instability, the Patellofemoral Study Group really in consensus thinks at this point that we should address that instability concurrently. So fix cartilage, do an MPFL reconstruction, and get them moving. We talked about this, but marrow stimulation has very little role for me in the patella. It's poor results. There's less cells, fibrocartilage, the high shear environment. If performed, it should be done mini-open. Does AMIC increase our ability to use it in the patellofemoral joint? After reviewing the data, I'd say that we need more information before I can make an intelligent choice in this, and I'm not currently using it. Haute autograft, there's good series from our friend Diego Astor in Brazil and out of Rush University. This can be done. It is done across the country and across the world. The outcomes are quite reasonable for the patellofemoral joint. Like most of you, if you can do this for small defects, they return fast because it heals like a fracture, so 5 months and 90+%. But I only get to do Haute autograft once or twice a year because I just don't have these small defects. And I don't want to do more than 2 plugs. And I think that I have better options when it gets to be the larger lesions. For Haute autograft, we want to drill. There's definitely mismatch issues that we have to deal with. And donor site morbidity, as Martin alluded to, which I think is real and very important. And so I don't use this very often. Will the fresh pre-cuts fill that void for those small defects, the 10 to 16 millimeter ones? I'm really not sure. And then for large, we've heard all about cell-based repair. It's really the workhorse. Yeah, it's 2-stage and it's expensive, but we're talking evidence, 15 publications for large defects, favorable outcomes up to 20 years, patient sat greater than 90%. This is a large series, Tom Minus and Andreas Gamal, Patella, ACI. These patients do really, really nicely. This is similar trochlear ACI outcomes in multi-center, where there's increased outcomes for very large defects at midterm and longer follow-up. This has been the workhorse, as you see here, 2nd generation ACI. The Summit trial was the largest RCT in our space. Dan Saris and others showed us the superiority versus microfracture. And Vibble talked nicely about the reasons we might go to Macy. Americans really only have a couple of years of experience here, but there is a long-term follow-up with good subjective outcomes and normal or near normal MRIs. And the cartilage signal did correlate to clinical outcomes. And here we see ACI versus osteochondral allograft. And you can see while the timeframes for return are longer, upwards in that 9 months or higher, the percentage of returnees to sport is quite good. And so there's a lot to cover here. I think I hit a lot of the basic principles, and I do want to leave room and time for a discussion, Peter. So I think I'll stop there, and we can bring up any other points or any of the techniques with less evidence that I really didn't mention yet in this talk, if people have specific questions for them. And I thank you very much for your attention.